Hello and welcome. My name is Faizan Arshad, one of the co-hosts for EMSNation. Welcome to our inaugural podcast episode where we bring the very best of evidence-based medicine to EMS. Today we have the pleasure of having a conversation with Dr. Paul Pepe, the original Eagle. And in this podcast episode, we launch into how research ultimately led to Dr. Pepe's career in pre-hospital medicine, how he tested his belief, the earlier the intervention, the better the outcome for each individual patient. He also talks about the very beginning of physician response programs in the pre-hospital space, as well as the history of the anti-shock garment, which he affectionately calls the instrument of the devil. We go on to proceed challenging the sacred cow, what we call modern-day Dogma-lysis. And then he also really digs into how a group of online medical control physicians banded together and ultimately formed the NAEMSP, the National Association of EMS Physicians, and how that brought about the formation of the group The Eagles, a consortium of the 50 largest EMS medical directors in this country. Please stand by and get ready for a wonderful podcast episode with Dr. Paul Pepe. Cheers.
I think that maybe a good place to start as an inaugural takeoff on this for you is how I got really enamored of pre-hospital care.
I think that would be a lovely story.
That's fine. So it's actually a great story in some respects, in that I owe a lot to my mentors and the great example I had from especially people who trained me in the Seattle area. I originally started off as a critical care doc and was doing some fairly high-powered research that got pretty well known, etc. I was really pleased in terms of the cooperation I got from various services. Mm-hmm. But one of the things I was looking at was adult respiratory distress syndrome, which was like this worst case scenario, sepsis, etc., in the ICU.
Iron lung.
In the sickest patients and so on. We were saying if we could prevent this in the first place, it'd be pretty cool. So if we could figure out the mechanism for getting it done, that would be kind of a way we could maybe find the right drug. So for example, we were going to get the various we thought it was due to some inflammatory process that was going on. And so we thought if we could get the various blood factors that are out there, leukotrienes or arachidonic acid, complement, various blood factors are out there. We know today, for example, IL-6 correlates really well with who's going to get ARDS or lung failure and all that, and various other problems that will go on. I was collecting the blood work to see maybe we could predict which one of those things lights up, and then we can maybe find the right drug or the right whatever intervention to help prevent the devastating lung injury. In any event, as we were going along, I was doing a study of people who had risk factors for ARDS, and I thought, hey, maybe I can collect the blood along the way. But man, collecting in the emergency department, maybe even that's too late. Maybe we should do it even earlier than that.
Sure.
Okay. So I went and put together a proposal. This is the days of whiteout and typewriters and things like that. And so it took a while. And then the library researchers we didn't have PubMed to look up. And so I did a lot of work to prepare for this. I mean, it was several weeks. And I went to see the head of the emergency services, who was also the head of the paramedics for the area, Dr. Michael Kopis. And as I came in to visit with him, he essentially his typical self, which is very laconic and very to the point, monkey business kind of guy. And he was doing his paperwork, going through his things as I came in. And he said, "Come in," and hardly any eye contact. He's still doing his thing.
Sure.
And I said, "Well, sir, I'm here to make a proposal," and then all of a sudden he said, "We'll do it." And I said, "We'll do what?" He says, "We'll collect the blood work for you." I said, "Well, how do you know about this?"
Wow.
He goes, "I talked to your boss." And I said, "Okay." He says, "You just leave it here." And I said, "Okay." So I was thinking I did all that work or whatever. So I was turning around and ready to walk out. And then all of a sudden he said, "Well, what are you going to do for us?" And I went, "Oh." And now he's looking up at me. And he's like, "I talked to your boss." And he said, "You think outside the box." And this is the first time I ever heard that expression. This is like the first time I think it's ever been used, etc. And he says, "Personally, I don't think you've ever been inside the box." And so I'm sitting here going, "Okay, is that a compliment or insult or both?" Yeah, right. And he said, "Listen, here's what I like from you." He said, "We'd be glad to collect the blood work. You can even see how they do it. It'd be good for you to understand that, what goes on, what the logistics are, and what the restraints, limitations, and the quality and all those things. But more importantly, I'd like you to go out there for your own sake and not only learn how important it is to be out there and making sure it's done well. And maybe you can give us some insights in doing it differently. If you can come up with a better way. We have kind of a philosophy that we want to continually re-engineer ourselves. Is there a way to do it better? We want to keep rethinking it and rethinking it.
Of course.
I said, cool. So, anyways, next thing you know is I'm out on the streets, and I was out there and it was a different world. So the one quick, I guess, anecdote I'd like to say is maybe the first night I was out, we went to a department.
Would you help frame the time for us? When is this all happening? Yeah.
Okay, so this is circa 1977. I guess this particular time is 1979, end of the 70s.
Understood.
There. And I had been used already by him to go out with the medics and certify them as what we'd have called DACA vals. And I was one of the 3 or 4 people he had chosen to do this. But when I came to this particular thing, I remember going out and making a run out on the streets. And one of the first runs I ever made was, somebody who was in an apartment building. We heard it was a possible overdose. Well, when we got there, the medics sort of picked up on a vibe. They pushed me aside, and a gunshot went off. So we had to understand that medical care was in a different environment there, and it was kind of interesting for me to go through there and have that kind of experience. But I think the most important run may have been the second run, which was we were called out to a small cottage on the north side of Seattle for a possible DOA. Over the years we've made some really fun, possible DOA calls, even DOA at the funeral home. I remember one guy went into rigor mortis in the bag in the back, and he moved or body shifted, and the guy driving him freaked out. Just that fun kind of an interesting anecdotes that you always have. But this was a really important anecdote to tell, is that I made this run up to the north side of Seattle, and we came into this house, and there was a stereotypical little old man there, and we were coming with these big, muscled firefighters and all that. And he says, "She's gone, isn't she?" And we were led into the back room where there's a small, cramped bedroom, and there was an emaciated shell of a body of a woman who coughed out her life's blood from the cancer that had riddled her. And I realized at that moment in time, well, she was clearly gone and emaciated, nothing, but it struck me at that time 2 things happened. One is that this wasn't in some family room at the hospital where it's very, in a sense, a sterile environment where you can quietly talk to them and it's on your turf.
Sure.
This was their inner sanctum. The person's home is their castle, whatever, but this is their inner sanctum. It was the pictures of their grandchildren, the trips from their honeymoon and all that. And it was an awesome responsibility for me, or a privilege for me, actually, to be there at this most solemn moment, be in their inner sanctum. And I came in with the greatest of respect for this. And the second thing is I really also, the privilege of being able to do that, or to ask someone a question they probably couldn't tell their mate of 50 years, or invade a body with an IV and just take it for granted that we can do that, is an amazing privilege, and that moment helped me respect it even more. And the second thing is I felt a great sense of inadequacy. I came from this major ivory tower. We had some of the best survival rates. We were very pleased with what we were doing. And yet there was nothing I could do for her. And what really hit me was that she was not our patient. He was. He was having the greatest pain of his life. This is the most solemn moment of his life. This is his mate of 50 years is now gone. And there's nothing we could do to replace that, change that, or do it, except to be there and to care for him. And so my philosophy that you can read about over the years came about where I started really saying that as far as I'm concerned, anybody who comes to work for me, what I do is that we don't treat people or manage cases. We care for those patients. We provide care for them, C-A-R-E, and I emphasize that. And I always have had the philosophy that we will treat everyone as boldly and as aggressively and as compassionately as we'd like our own family members to be done. So I hope that philosophy is carried through. And I have to say I learned a lot of that because of my mentors there in Seattle, who are just profoundly brilliant people. Who quality CPR was of course back then for them. Early pre-hospital care was of course for them. And as an ICU doctor, I started to learn that an ounce of good pre-hospital care could probably save a ton of ICU care. And so my mantra over the years has been the earlier the intervention, the better the results. And the corollary was, again, an ounce, or if you're over in Europe, a good gram of pre-hospital care, you'd save a kilogram of ICU care. So I started to say, I'm going to take my practice more and more to the streets. It wasn't just to collect the blood work and help me with my research, but also help with this whole, cascade of events.
So the inception was you had been interfacing with the medics in pursuit of academic research. You had started going more and more pre-hospitally, and then sort of the human element impacted you more, and the concept of translating critical care from the ICU to the ED to even then the pre-hospital space was born.
And in fact, I started changing my whole philosophy where they used to always say that it was an extension of the emergency department into the streets. I'm like, no, it's the other way around. It's like, for the patient's point of view, the event happens, and that's where things start there. So everything we do, from the dispatch office, that first interface with the patients or their families, to the first responders, to the medics, to the emergency department, right on through, whether it's the OR or the ICU, there had to be a stewardship of that care and optimizing. And I found with my studies, when I was trying to make sure that we were following and being compliant with the protocol, that people would drop the ball sometimes along the way, or information wasn't passed on, that we got to monitor for a pneumo better, or whatever it might be. There might be a small one. I started beginning to understand that you really had to steward this whole continuity of care for the patients, and thus the whole issue where I learned from Peter Saffer about concepts of like the linkages between these things, and his crews, really formulated this whole chain of survival thing that I presented to the city council back in 1983 in Houston when I arrived there. I felt like I had to take ownership of this whole stewardship because I felt like I meet these people in their homes, there's the family members, and I'm going to make sure with grandma or the husband or the child that I'm their advocate. I'm there making sure that that care is continued and stewarded, and they have a friend in the system all the way through. And we've tried to do that as best we can in every community that I've worked in. So it all started there on the streets, back, about 4 decades ago. And it really is kind of a thing I'm very proud of, and have been part of the Seattle program, and proud to have been of service to the folks that work there.
Amazing. So help us connect the dots. In 1976, we begin pre-hospital research Seattle. 1983, Houston, Texas.
Yes.
What happened in the middle?
In the interim, I actually was thinking about going to do ICU work, etc. And then when I was going down to Houston later as an interview, someone saw my resume apparently about me being on the streets. And they said, how would you like to run our EMS? And I said, because apparently there was a new state law coming out in Texas to say if you're going to have an EMS service, particularly an ALS service, you better have a medical director. So I said, what's EMS? They said, paramedics, 911. I said, you mean like the Seattle Medic 1 program? Because that's all I knew.
Gotcha.
So the cool part was, one, is I was a person who was used to doing research. 2, I was a person who had no preconceived notions about what you were supposed to do. But 3, I actually did have good perspective because I was in a quality system and just didn't know it. I just took it for granted. And so it was really pretty cool. So when I arrived in Houston, they said, can you help us with this? And they said, why would limit yourself to a catchment area of 20 or 30 ICU patients when you could study 160,000 runs a year?
Absolutely.
So I said, okay. So I talked to the people there and who were going to be recruiting me, and I said, well, if you give me a few months to sort of help them out and get this thing started, I want to come back and run the ICUs as you've been recruiting me to do. I published a couple of major papers that I was being recruited for around the place, like the autopeep paper and the sepsis syndrome concept and a few other things. I was destined to be this ICU director, but having that background, and then this happened to be someone saw my CV about helping out the medics, got me on the streets. And then once I did that, and that leads me to another interesting story.
Yeah.
Which is, so I'm there the first day, November 1st, 1982, actually, when I started there. And I was saying, can I review the charts from last night? And can I, and they're all looking at me like, are you crazy? Because we had 700 runs last night. There's no way you can look at that. And he said, and one of the chiefs there, a person I just totally respect, if you go to, you look at the protocols in Houston right now, or you go look on the walls of most ambulances, they'll have the Holder rule, which is we will treat everybody as aggressively as boldly and as compassionate would a family member. And that was Dennis Holder. And Dennis, who's no longer with us, was an incredible firefighter. He was just an incredible guy, but also a visionary. And he was in the streets. It would never stop him to stop off to get a cat out of the tree or to do CPR. It was never beneath him to do that. And he was just an amazing man. So I'm in with all the chiefs, including the fire chief. He walks into another room, comes out, and he has a walkie-talkie and car keys. And he goes, here's the keys to your responsibility. Here's a walkie-talkie. Go out there, see what's going on, and make it better. And that's what I did. I lived on the streets, and it was easy for me to do it. I've been on the streets of Seattle over those years. And so it was an easy thing, and he was absolutely right. And so I began to see what the issues were and was able to do it. And the best part is I was able to do it by example. And I knew that eventually, and those are some of my favorite years, by the way, because their survival rates were pretty low. And part of it is, they were taught by people who worked in hospitals, not in the pre-hospital arena. They didn't have as much support medically or insight. People were making decisions at an administrative level that weren't based on their suppositions versus what you would see actually in the field. And by having that kind of experience, I was able to say, hey, here's what's really going on. This is what I think the problem is stemming from. And so slowly but surely, things got better. And it was so much fun because we'd go resuscitate 4 or 5 people a night, and several of those people would eventually go home, and the guys were catching on and going, this is so cool. It's something I picked up from Seattle we call Plan A, so we introduced the Plan A concept, which was how to resuscitate people. And it was really an effective, pragmatic approach. I mean, everything, like if you were alone as a medic, you found a cardiac arrest, you're charging up the paddles with the left hand, pressing on the chest with the other hand. Mm-hmm. You knew that took exactly 7 seconds to charge up, so at 5 seconds you came down, and you saw, it is VF, and you shocked them, and you pull up. If it wasn't, you killed the charge and go right back. So it was just efficiencies, focusing on uninterrupted CPR, all the things that we talk about today.
So minimally interrupted compressions, 1982.
So, and we were making sure we weren't ever zealously ventilating people. Being a critical care doc, I knew that ventilation should match perfusion, so you didn't have to give a whole bunch of breaths, maybe one every 10 seconds. So the good news is that we were doing pretty quality stuff, and we were getting people back. What I love best about then is that, this is like early 1980s. I wasn't doing how much paperwork I did? 0. And it was fun. I mean, nowadays I go into the emergency room and I'm spending most of my time on the computer documenting things. And I'd rather be seeing patients and interacting with them and all that. And that was a great time.
Was this the first example of a physician response program? Was anybody else doing that in Europe?
There have been people who have been doing it. First of all, Dr. Kopis had it set up so in Seattle we were doing it. And early on, when Dr. Cobb had originally started the program, there was a bunch of docs who were going in the field. In fact, they were in a way my role model because we always thought that the docs helped start those things. And then eventually when they translated it over to, that's maybe for another story, I'll tell you about how that all got started in Seattle. But the bottom line is at the end of the year, the docs were teaching these original recruits how to be a physician-like in the field, and they were role models. And so at the end of the year, they could actually go to the state legislature and say, we trust these guys so well that we would let them take care of our family members. And I mean, that's why that thing, they said, it's on our license, you can hold us accountable. That's how much we feel like we trained them. So I think I was fortunate because I had the early role model that you had to be out there and be with them. It's an apprenticeship early on. And it's not just something you put them through a paramedic school and then you just put them out there. It'd be like sending a medical student and say, here's how you do a spinal tap in the lab, and then you send them out, and they don't know anything about, things that you might hit as you do that spinal tap, or little tricks of the trade, or whatever you walk them through. Or you could teach them the sniffing position, in the laboratory or in the OR, but then in the midst of the battle, can you show them some tricks of the trade about how to do it right, so they will never miss that intubation. So I think that was for me a natural, and people had done it before me. Perhaps, though, what I did do is I really kind of made it kind of a full-time endeavor for the first time. And I started writing papers at that time about the role of the physician in the pre-hospital setting. And all I was doing was reflecting what I had learned from the Seattle system and my mentors there and the previous examples. In other cities, people were doing it up in, for example, in the up in the Wisconsin area, such as Madison. Mark Birnbaum was out there doing it. I mean, Gene Nagel was kind of doing it in Florida. There was Marty Keller. I mean, there were folks setting up these kinds of programs around the country. I think what I probably did was I had the opportunity, being in a huge system like Houston, to say it's not just a full-time job for one person, but maybe multiple people to do this right. And so that's probably how you can envision I was kind of, in a way, a pioneer from that point of view, but not from the point of view that was some kind of original rocket science for me. I just was trying to But I think I formalized it and started training other people to do the same thing.
So EMS was also evolving nationally at this point in time. So we're sort of mid-'80s.
Yeah.
NHTSA had released some of their policy statements. We had started...
Who did?
NHTSA.
Okay, yes, yeah.
And we had started sort of developing the public model for funding, et cetera. So what was going on in the rest of the country, and how were people doing
medical
this?
directors, originally, it's interesting when they wrote up some of those original policies, one thing that was left out was medical direction. I mean, maybe it was taken for granted by the people writing it up, or they weren't being saying it's because of us. And so it got left out. And what we started seeing more and more was concepts of that there was loss of medical control out there. And what happened was EMS systems were evolving without that initial apprenticeship, that relationship. The doc who was streetwise, who could teach the people to, act on his behalf. And part of our mentality in Seattle was that you're delegating this practice to the medical director of the EMS system from the rest of the community, and we will guarantee that those people will give the same level of care as if I was there personally. And that's what we try to train people.
So they took ownership of the quality of care that was provided.
But we just didn't start, things were evolving. People say, hey, let's look at one of those paramedic systems, but they lost the insight about how the actual root. They forgot sometimes the M in the EMS, that kind of thing. And I mean, all well-intentioned, but it was just missing. And so you start seeing things about emergency department physicians writing up things about loss of medical control out there and so on. But we, in a way, had kind of abdicated. And so that's why I think that what we started doing in the 1980s was to try to bring back the central pivotal role of the medical director in emergency medical service, et cetera. And we saw that evolving in a good way. One of the things that hit me right away in a story I told earlier today was, as I got there, one of the medics asked me about the anti-shock garments, and I said, what are those? And they explained to me about this big blood pressure cuff thing that you wrap around. It raises blood pressure, and the pilots used to use it. And it did raise pressure, and it was actually, at that time, 1982, was required by law in 2/3 of the states. And, in fact, the ATLS guidelines said you put them on everybody if their pressure was 80 or less, or if it was 100 and it's symptoms or signs of shock in any way, you put them on. So it's required. But there was some controversy when I got to Houston because the surgeons there didn't want them. They said if they had to do crash laparotomy, they're in the way, just get them to us. We have to do a cut down. And so there was some controversy from that thing. I mean, one person even, the head of the trauma surgeon said it's the instrument of the devil as far as they're concerned. And I said, but if it keeps you alive to get to the hospital, should we? And so I have to give them credit when I said, well, why don't we just study it? So this was kind of the perfect storm in a way. I'm a critical care guy who had a different mentality about, perfusion, ventilation, et cetera. I was used to doing controlled clinical trials, scientific examination of things. And I walked into a world where no one had really done much of this at all. And so I didn't come in with preconceived notions, although I came again with a system that sort of said this is the kind of what a quality system does.
Gotcha.
But I didn't come in with saying, how do you do this, or why do we do this? And I was trying to learn a whole new trade. So I was constantly saying, why, or what's the basis for this, or whatever. So it was cool that trauma surgeon said, let's study it. And I said, great. And so I developed a prospective controlled trial. And today people call this evidence-based medicine, but it was just, it was just me saying, let's just do the right thing to make sure that we're not hurting or helping or, spending money on things we don't need to do. Exactly. And that's all it was. Well, it turned out, I thought the thing would not make any difference, or it would help. I was actually enthusiastic that it should help, because if you have penetrating abdominal injury, if it could really compress it, it could be, because it tightens up around the belly, that would be a good thing. Well, it turned out that it actually made things worse. And at first I'm going, wow, I wonder if I did a poorly designed study. In fact, when I went back, it turned out it was well designed, and I think somebody wrote it up, either the Cochrane people or someone wrote up and said that this was a well designed study, it was great. But there was a couple other differences, and one of the differences was that we were raising blood pressure. I thought, well, why is that a bad thing in trauma, And then later, some cases happened that came into our emergency department. One person, for example, with their arm cut off, and we plugged in 2 large bore IVs on the other side, and he had never gotten anything en route with the medics. And all of a sudden, boom, and the bleeding had stopped. The arm had been cut off, and then we heard there was blood all over the place at the store where this happened, and in the car. But when he got there, he wasn't bleeding. So his pressure was 75 and so on. Well, all of a sudden, we hear this blood-curdling cry. It's not from the patient, it's from the nurse, because the thing started squirting. So we had raised the pressure enough hydraulically, I guess, where we knocked off the clot or whatever we were doing, or diluting clotting factors, or just raising pressure hydrostatically, and he re-bled again. Well, we got control of that. But it made us think, I wonder if we do this internally with, the next minute, a guy with a stab wound comes in the next room, and I'm going, 2 large bar IVs, and I go, wait a minute. And you start thinking, I wonder if we're just not seeing it, that's happening. So that led to the fluid resuscitation studies we did. And so we started really challenging a lot of sacred cows. And sometimes that got me in hot water back then because we were challenging sacred cows. But it's kind of nice to see how, eventually some of the things that we had questioned up front were now, become mainstream things that people are starting to also validate that in their own areas, particularly with the military. Same thing with the ventilation stuff. Since I knew that ventilating too much was, we eventually showed that was an issue, and that led to one thing another, where we started looking at the compressions only CPR, even in the 90s, etc. It was a fun period of just saying, well, why? Why are we doing it this way? And to research things. And just jump ahead today, my whole approach has been that I think we've spelled research wrong. It should be spelled RE-SCARCH. We should always continually research and rethink. And I owe that all again to Dr. Cobb and Copus in Seattle, who are saying we need to constantly rethink, retool. Is there a better way of doing it, and not take it for granted that we're there. And that's been a great legacy that they provided for me during that period of time.
So as the consortium of EMS physicians or pre-hospital physicians was growing across the country, then how did you come to form or have the idea to form the group collectively, the Eagles?
Yeah. Well, even before the Eagles, think about it. In 1984, I've just been to Houston. I'm feeling a little bit on my own. I don't know if I'm doing the right thing or not. In retrospect, I probably had a lot better knowledge about it coming from a great system like Seattle, but I was still very, very insecure about, am I doing the right thing? I have the responsibility now for, 1.9 million people and the visitors that come to this city.
Sure.
And am I doing it the right way? I just had that sense of caring and responsibility, and not just taking for granted. And the added attraction for me in terms of being always questioning, is this the right thing we're doing based on my scientific background, even compounded that even further. The point being is that in March, I think it was January, February of 1984, I got something in the mail about a conference being held in South Carolina called the MedCop Conference or something like that, which was medical control physicians, which in itself sounded pretty patriarchal or whatever you want to say in terms of, MedCop. But anyways, I said, I'd like to go down and check that out. And apparently it was held down at Hilton Head, and I can't remember, I think it was the Marriott there, one of the hotels in the chain, and I think they had reserved 40 rooms, and about 300 people showed up for this meeting from around the country. There were a lot of people.
Amazing.
Yeah, there was a lot of people around the country who had the same concerns and whatever about, this whole issue about medical control or whatever, as they were calling it back then. And we obviously changed that to less paternalistic thing like oversight or, whatever, supervision, that kind of, or better, I like direction, because we were trying to set the direction that we were going to go in. So anyways, I went here, and in the hallway, I got there the second day of the conference. I think it was being run on March 2nd, 3rd, 4th, and I was there on the Friday morning. I think it was the 3rd, and about 11 o'clock, I was just arriving in for my flight, and a guy comes up to me in his khaki pants and his powder blue shirt and striped tie and blue blazer. And he introduced himself. Very, hospitable, gregarious man. His name was Dr. Raymond Fowler. And Ray was a medical director from down in Georgia, and he was coming for the same reason, like, I need help. I found out there were people in the audience that had really even more basic questions, like how do we do QA, or do we get malpractice insurance, or how do we get, is anybody getting paid for this, or whatever.
Exactly, yeah.
And so they're just really rudimentary basic questions. And it turns out that the majority of the people in the audience were not emergency physicians. We didn't have that many emergency physicians around. I mean, if I went around the country that time and told you who I thought were some of the best medical directors, they're like Jim Atkins from Dallas, who was a cardiologist. Mike Copus started off as a neurologist, okay? And still practiced as a neurologist throughout that period of time. Abrahamian was a surgeon. Dick Treat was a surgeon. I could go on, and they were from all walks of life and different practices, and they were all really great. But the problem is that the majority of the people, believe it or not, in the United States who were EMS medical directors at that time, and there weren't that many around as it was, were actually family practitioners, like, my friend George in Soldotna, Alaska, and some of them were the best because their hometown, he took ownership, he was on the streets with them, taught them in the streets, and all those things I had talked about, that was the roots of EMS, was in streetwise docs who was able to pass on as role models out there what to do, was a key factor. So there were people at that time. I went to the ASEP folks at that time, and they were going through their own growth spurts and identity things. So when we approached them about, hey, can we start a little section for these docs? They're all got together and they're asking these basic questions. We'd like to sort of maybe give them a home. And the attitude at that time was, are you an emergency physician? And at the time I said, well, I run a large emergency department in Houston, does that count? Whatever. But it was just kind of an interesting, it just had to do with the personalities at the time and so on. So we actually all got together, a lot of the people who were at that meeting, Ray Fowler, myself, Ron Stewart from Pittsburgh, and so on, and said, well, let's just start something for these folks. And we did. And that, over the next year, we had another meeting in June up in New York, at a place that was hosted by a guy named Sandy Kuehl, and he was the medical director for New York at that time. One of the people that helped start that South Carolina meeting was a guy named Bob Bass, who later became the director of MIMS, etc. And we all got together and said, well, let's form something. So for the most part, Ray Fowler and I really put the nuts and bolts into it. And over the next year or so, started founding things. And we had a meeting. We named the thing in the fall of that next year, 84, I should say, because the original meeting was in March. And we named National Association of Physicians. We said, Ron Stewart is the best known person. Let's make him our first president, and then we'll elect people after that. We'll create bylaws, etc. And so slowly but surely that started coming together, and we ran our first meeting in October of '85. And for the first time, we said, we have advocacy for you. And it was a tough decision because I was not in favor of creating another place where you had to put your money in, another splinter group, another what I would have preferred to have had the home at ASEP, for example. But there was a need out there, and we wanted to deliver it. The organization started taking root, and within a few years, it really had become a very important organization with over 1,000 members and growing, and it's become pretty influential today, etc. And it was all largely because this guy coming up to me, who I immediately liked at that first meeting, who ended up being our first secretary treasurer, and Ray Fowler, and then one of our presidents later on. And all those people that were involved were just it was really kind of a cool thing to have a home base and an advocacy group for them. And so as you started seeing that as more, but the irony is that as emergency medicine evolved more, there were a lot of people who had been previous paramedics even, and they wanted to get back to EMS. And so you start seeing the evolution by the 90s of people who are, if they weren't doing it full-time, or doing fuller-time EMS functions at their universities or in their hometowns and so on. And especially as the new generation grew, we put on medical directors courses, and at first we're doing it for family practitioners, and by the end of the 90s, a lot of the people in the room were emergency physicians who had come out of residencies, and we started getting in the idea of fellowships, and eventually the whole subspecialty took root, modeling after a lot of the things that some of us had done back in the 80s, etc. But to give you one last perspective that people always ask me about was that in 1996, I was recruited away to Houston. I have to admit I was getting a little bit more mercenary at that time because I had kids, so I thought when I was offered a better salary to be a chairman of a department of emergency medicine up in Pittsburgh at the Medical College of Pennsylvania's Pittsburgh campus, I went ahead and did that and was excited because I was getting to work with people like Jim Menegazzi over at the University of Pittsburgh, who was just a terrific person, one of my favorite people. But there were some growing pains as I got there at first, but eventually brought me in a couple of people there locally. I was not involved directly with the EMS because I was involved more with the trauma center, et cetera, in my department and the training programs there. But I was approached by some medics actually from the Pittsburgh area to say, hey, can you tell us, you're always doing all this cutting edge stuff. We want to know what we're going to be doing 10 years from now.
Exactly.
And I said, well, I don't want to step on any toes for your medical director should be doing that stuff. He said, well, we want to hear what you have to say. I said, tell you what if I put a conference on here that anybody can come to? And I don't want, because I just want to be seen as someone who's trying to interject myself into anything here and all that. And that ended up working very well because one is I didn't have to step on anybody's toes. I did it, and there was a person in the audience from the Department of Health who later said, "How would you like to be our first, Commonwealth Emergency Medical Director?" So we put on a program, and it was kind of interesting because they were asking me to do an educational program. And just that day, when they were asking about it, I was getting a phone call from Ray Fowler, my good old friend from NAEMSP days.
Of course.
And he was coming up because he was the inaugural program director for what was now called ITLS, BTLS at the time. And he was coming up to do a course for the University of Pittsburgh. And then I also heard that my friend Jeff Clausen, who was actually almost came to work for me in Houston, was going off to do one of his dispatch courses there. And I said, "Hey, what if you guys stay over? You stay an extra day, you come a day early, and we put a course on." And the next thing you know, it evolved, and I started calling David Purse out of Houston. I started calling out Jim Dunford out of San Diego. Before you know it, we had about 11 or 12 people that gave these bullet talks. We could all give a talk at the latest thing in these areas, and it went over really well. And in the audience was, again, the director for the Emergency Medical Services Bureau said, "I need a medical director. I want this kind of stuff being done across the state." So that worked out pretty cool. So I got to work as the Commonwealth Emergency Medical Director in the Ridge administration while I was doing this other thing. So I kept myself, and I started learning more about all the different kind of everything from the mom and pop shops to the fire department systems, the third party systems in Pennsylvania, and all the various things that the various medical directors went through in their small towns versus the big cities. And it was just a great eye opener for me again. And that was kind of a nice time. But the interesting thing is that meeting that I held, it was so well received. We had only advertised it for 2 weeks, and about 150 people showed up, and almost every one of those evaluations said best conference I have ever attended. So the next year we were asked to put it on again with the support of the state, but then that's when I was recruited to Dallas. I got a phone call from one of my old mentors, the chief of surgery back in Seattle, who said, "We want to start a program down here in emergency medicine. It's that time to do this at Parkland." And I'm going, "Cool." And I said, "What do you need?" He says, "Well, we have a looming RRC visit review committee, and they say we only have 15 faculty, you probably need 30. I said, "Oh, I'll put the word out and help you recruit people." He goes, "Well, the other thing is that some of the people we have, I will just probably are not always up to stuff. Some of them are A to A plus, some you may not. So we may need to recruit, a stronger team."
Gotcha.
I said, "Well, we'll help out." He says, "Well, it's going to cost, blah, blah, blah amount of money you guys have." They said, "Well, that's the other problem. We're running out of money." And then he said, "Well, maybe you can leverage the EMS system with research and blah, 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 blah." And so the next thing he knows, he goes, "Well, that's falling apart too." So I said to him, "So listen, is this a recruitment call?" He goes, "Yes." So it was great because Parkland was the mecca for me in terms of trauma care. People like Ron Anderson was there, Jim Carrico, the trauma surgeon I was telling you about, who's now the chairman of surgery there, who was the head of recruitment. I couldn't have been more pleased to go work with people like that I just held in the highest esteem, and it was just so flattering. So I went down there and started the program, and I brought the Eagles with me. But right about that time, and by the way, the Eagles got their name because the next year, when we were, the conference I was running was called EMS State of the Science, because that's can you prevent some scientific data says state of the art, state of the art. Yeah. That's cute, but let's call it State of the Science just as a play on words, because we'll have some data for them. Okay, so that's what we called it. And but when the year I got to Dallas, we kind of skipped the first year, so there was 1 year we didn't run the Eagles because we ran it in 98, 99, 2000 I didn't, but 2001 we did it again. I had called in all these great people by that point in time from around the country, and we thought it was a cool idea, and we'd been talking. Mark Eckstein now from LA, and so on. And when some of the industry media people saw that all these people were coming along, they go, "Wow, that's a gathering of Eagles." So I thought, that's a cool thing, and it kind of stuck. So we just said, EMS State of the Science, a gathering of Eagles, that kind of thing. So it was so cutesy that I said, "Oh, we'll stick with it." And it was interesting because, I was kind of like we would banter about with each other at these meetings and say it's a gathering of egos or something. But ironically, it was just the opposite, and the audience soon found that out too, because this was a group of people who eventually, by the next year, they were from these big cities, and they were responsible for millions of people, literally in some circumstances, or at least hundreds of thousands. And are we getting it right? We felt like there was a sense of obligation. It wasn't like it was we weren't bragging that we were in charge of these. We were more like, wow, we have a sacred responsibility to get this right. And so it was great connecting with each other again and having it. Again, I was always counter splinter organizations. I didn't want to form a new organization or anything like that. I always try to be respectful of the Heart Association, of ASAP, NAEMSP, whatever it is. But what we found was there were kindred spirits. These were people who were, of like minds. We had the same kinds of responsibilities. We were, in a way, scared that we were doing the right thing. And to get together and confide in each other and say, how are we handling this? So Amazing. It's like the dispatch thing then. I said, I'm going to just give compressions only at the dispatch office. There was no standards for that. And everybody else is going, yeah, but is there a point where you start the compression? Start the breathing? And I said, I don't know. So we actually had some differences there, but we agreed on the differences. So half the people went compressions only until help arrived, and some people started it out at maybe 5 minutes, they would do it. But it didn't matter. The fact that we found kindred spirits and we can move along, because the Heart Association guidelines had just come out in 2000. There wasn't going to be any change for 3 or 4 years. But if you got a bunch of people who were responsible for 60 million Americans at the time, and they were in the same, could support each other on it, it really helped with that. And we always kept the Heart Association in the loop, the EMS physicians, ASAP, made sure their national presidents were at the meeting. And we just really worked hard. Something happened, though, that year, which was 911. So all of a sudden, at the end of that, there was a need to sort of, I got calls I was good friends with the Surgeon General. I was close to various other people that I've supported in the federal government in different areas. And they were asking for help, and what do we do, and how do we get the training out, what's the best way of doing it. And I was fortunate because I said I can make calls to all the other places and we'll do an inventory of what's going on. So I'll go ask LA and I'll ask San Diego and I'll ask New York and I'll ask Boston. So
if I may, Dr. Pepe, that is amazing. And it sounds like that's the perfect place to put a stop, leave the audience in suspense, and perhaps take off on a second episode. I want to be respectful of your time. I have a few quick questions to ask you.
Absolutely.
We talk about high performers and we want to dig in or dissect really what it is that makes you Paul Pepe. So if I might ask you, what's your ideal morning, or how does your morning start out? What time do you wake up? Do you have any morning rituals that you practice?
Now, that's the thing is that, I do like a good cup of coffee and a hot shower.
Okay.
Yeah, whether I'm in the midst of Katrina, which I'm going to talk about actually in about an hour or so here. The one thing I would say is we're going to get a shower and we're going to get a hot cup of coffee.
Sure.
I'm so variable depending on what's happening. I can't tell you there's a routine. There may be nights I'm up till 3 or 4 in the morning running the streets or doing whatever. And there are nights, spent some time with my wife, we went to bed early. So it's just, there's no way of saying I have a particular day. But I think that I've given some talks on this there because people were asking me, how have you been? I've written some papers on what defines the success of a medical director, and some people think it's survival rates or how many scientific studies you put out or whatever. I think those are all kind of system things. I think what I think of, and to answer your question, I think better, is that what defines success is how you handle the day-to-day stuff that comes up. And I gave an analogy to something I learned from my grandfather, which was the Odyssey. And what made Ulysses a hero was not that he got home to Ithaca. Okay. What made him a hero is how he handled all the stuff that got in the way on the way to getting there. Okay.
The journey.
It's the classic thing. It was the journey, not the destination. But it was more than that because it was also that every day something comes up that's a challenge that it could be the end, it could be whatever. It's how you navigated through that and survived through all that and still persevered. I'm going to have Terry Valenzuela, who's been for 3 decades the medical director of Tucson, give a talk at ASAP, and the title of his talk is going to be Sagacity, Veracity, and Tenacity. And those are the virtues you have to have, is to be a truth sayer, that you have some wisdom about how to do it, just as Ulysses was a very wise person, and that's what characterized him the most, and not drawing guns and being carefully, strategically learning how to navigate the waters between Scylla and Charybdis, or how to deal with the Circe. So
along the lines of Greek Odysseys,
yes,
if I might ask, which book do you gift the most?
It's Wind, Sand, and Stars. If you're familiar with that, Saint-Exupéry was the author of The Little Prince. He was a pilot that flew the males. He was really an interesting guy in that he did this story about his days when he flew the males across This is back in the teens, in the 1920s. And there's different sections. One's called the men, the tool, the elements, etc. But there's one thing in the men where he's talking about the other pilots, and they lose one of their guys. And he talks about, and it's a great section, and I've been very privileged because there was an award made in my name. On the bottom, it has some of the quotes in it. And just to paraphrase the quote, it says that we all have learned that there is no greater gift in life than that of a companion to whom one's bound together with ordeals suffered in common. Amazing. It's the concept of the foxhole companion. It's like with the Eagles, it's like we were all going through the same thing, and we're basically, we've been united, we've been brought together because there's nothing but human relations is what it's all about in the end. And so whether it's dealing with our patients or our comrades or whatever, and the cool part about the Eagles, again, is that these are people that aren't coming together with I did this or I did that or pecking order stuff. It's just the opposite of any gathering I've ever seen before. They're there sincerely getting together constructively. But to go back to the question about I live my life with just if someone calls me up who's a friend of my wife and needs some help, I'm there for them. If it's a patient who's trapped in a ditch somewhere, and I'll go down to that scene, and I'll make sure if the family's standing by that we're caring for them. So part of my day is spent to serve others, etc., and to be there. And no matter what it is, I try to bring that mentality, whether it's in the emergency department, in the streets, or even if my own family or my friends or whatever it is, to be able to extol that kind of mentality. So.
Lovely. Speaking of serving others, a selfish question, if I may.
Uh-huh.
For the young EMS physicians, I am scheduled to take my board examination in a month or two.
Okay.
Do you have advice for the young EMS docs out there?
Well, the main thing is that I'm not sure always that in every exam that I take that reflects whether you're a good doctor or not. It really is a certain amount of knowing, a certain amount of knowledge base about things. And you'll do well if you've been through a fellowship and they've done the training and they've met the curriculum. You'll know all the stuff that's on it. Well, that's, getting past the exam is one thing. Remember last time, half the people didn't pass, and a lot of the people who didn't pass were people I would say are the actual experts in EMS. Don't sweat the exam as much as do the job on a day-to-day basis, and just like everything else, study for the exam, but look at it in a more pragmatic fashion that get past the exam, and don't worry about it. You'll do fine. I'm very confident in that particular. The main thing is what I want you all to do on a day-to-day basis. If that I'm supposed to be sending a message to the young champions out there, is just retain that mentality that every decision you make. I was to say whether it's a protocol you write or transportation dispositions. If it was your family member, your mother, your child, what would you do for them, and try to make those decisions. If it's an individual case, whether we should transport this person or pronounce them dead, or is it what we're going to do about the tax rolls, even if we get this new piece of equipment with you. So when people ask me, what do you think about this device? There's controversies. Would you have it? I said, and I think, I'd probably want it if it was me, And or if I'm doing a scientific study, I'm out there and say, would I enter my family member into that study? Do I feel ethically that it's the right thing? And those are the kind of things that'll get you through the day on a day basis. So then you got to be patient. You've got to have tenacity, which means that you've got to be patient. You can't win the battle overnight. You can outlive them. We have kind of a standing joke amongst several of us where, so that worked in the big cities where it's very political. And we, remember they have the thing on Saturday Night Live about the 5 Timers Club?
Yeah, absolutely.
Right? Well, we have sometimes the 6 Timers Club. In other words, you've outlived 6 fire chiefs or 6 police chiefs or whatever. And that's a good sign that you were politically savvy, you knew what you were doing. And political savvy doesn't mean that you compromised or anything. It just means that you understood what the other needs were of the other parties, and you worked around that and made it happen. And you got yourself respected and well-liked as a result in the long run. And the coolest part for me was that there may be people who said, well, I didn't really like you personally, but I really respected your work ethic, that you're there round the clock, and all that. And I actually now really like you a lot, that kind of thing. Those are the kind of things that make you feel that if people can come up and talk to you like that and do that, because you exude that you care about them and you care about the patients. And those are the best, I guess, words of wisdom I can leave with you, etc., as you make your journey to Ithaca. Okay.
Sage words, Dr. Pepe. Thank you so much for your time. Last question. Where can people find you?
I don't know. Usually on American Airlines.
Fair enough.
Right.
On the internet, Twitter.
It's like so. It said, "When's your birthday?" And I said July 13th, and they said, "What year?" And I go, "Every year."
Every year, of course. Lovely.
It's the same kind of thing. No, I'm actually, the best way to find me really is through email at the University of Texas. I don't follow any social media, and whether that means because I'm an old fart or whatever, or it might be. Actually, I try to keep my life as less complicated as it can be, because as it is, I already get 1,000 emails a day, and
you do.
I got to sort through them.
And you respond very quickly. Thank you for that.
I try to be. Yeah. So that was one thing. When I gave a talk once about what it was like being a medical director, and I gave the analogy of the Odyssey. And I said, for example, there's gods and demigods, and the gods are the politicians who can have whims and change things, and the demigods are the chiefs and various other people. And then there's the sirens; those are the vendors, or there's the what I'm saying. There's just the union and the administration is still at Charybdis. So there's just all those kinds of analogies. What I basically said during those periods of time is that as you make your move through there, one of the most important tools I had was, I had the legacy of the Trojan horse at the various studies I did, or kind of my people say, hey, he came up with this really cool stuff, and those are the analogies there, that made Ulysses famous. But more importantly is that the radio, the communications was my bow. His bow and arrow was the big thing, that he had where he wins in the end. But my radio communications, my phone communications, that sometimes people even make fun of because I have so many communication devices, is that I am there for people. When they call me, I pick up the phone, I go, yes, even if I'm in the air sometimes, right?
Amazing. Yeah, absolutely.
Yeah, and you know that for personal experience. And I think being available to people around the clock really made a difference. And it actually decreased, some people might think that's not time efficient, but it actually improved my time efficiency, because eventually people felt like they cared about them. I would have less problems with unions, or less problems with individuals feeling like, that became HR issues, because they knew someone cared about them. So it applies not just to, to the patients, it also applies to your colleagues, and it applies to those who serve with you. And to be available to them, that's really your ultimate tool that helps you win the war, by being available to people. Okay.
Amazing. Thank you so much for your time, sir. I suspect we'll probably meet again for an episode 2.
Okay, good.
Cheers.
All right, excellent.
Thank you so much, EMS Nation, for joining us on our inaugural podcast episode with Dr. Paul Pepe. We'd like to start off by saying this podcast is an experiment. Our goals are to bring you high-quality interviews with leaders in EMS and really dissect into their insights, inspirations, and future inclinations in pre-hospital care. We'd also really like to develop a simulation series, bringing simulation to your tablet or smartphone so we can start working through drilling and training on high acuity, low occurrence cases, which we call halo cases, really to take and step up our care to the next level. And then finally, we'd like to develop an online community, a band of brothers and sisters in the pre-hospital space focused on evidence-based wellness initiatives. If you like what you've heard, please ping us on Twitter and Facebook, which are linked in the show notes. We'd also like to take a moment to recognize the EMS Wolfpack, which is building an international community of pre-hospital providers. Please find them on Twitter and follow them. In the next episode, we'll be really drilling into creating a push dose presser and optimizing your patient's hemodynamics in preparation for an advanced airway. Until then, this is Faizan Arshad wishing everyone a safe tour.